Today we're talking about a story that's as frustrating as it is fascinating, the ongoing BCG shortage and the new wave of therapies for non-muscle invasive bladder cancer. It's a question that's divided the urology community. Did innovation drive BCG off the shelf, or did scarcity open the door for innovation? In other words, which came first, the chicken or the egg? For more than 40 years, intravesical Bacillus Calmette Guérin, or BCG, has been the mainstay therapy for high-risk non-muscle invasive bladder cancer. Few treatments in urology have had such durable impact, reducing recurrence, delaying progression, and sparing thousands of patients from cystectomy. It's cheap, it's effective, and it's guideline-based. And yet here we are in 2025, and many urologists across the country are still saying the same thing. We just can't get it. That just seems almost unthinkable. I was around before BCG started when I was first entered practice and was actually part of the group that was testing it. And it was unbelievable when we started seeing some of these results. Great drug. So why? It's a perfect storm of manufacturing bottlenecks, the complexity of producing a live attenuated biologic, and the unprofitable economics of a decade-old low-margin drug. Merck remains the only U.S. supplier. There used to be two. And despite periodic assurances that production would improve, the shortage persists. The irony is hard to ignore. In an era of CAR-T cells, gene therapies, and bispecific antibodies, we still can't make enough of a century-old tuberculin strain? Come on, folks. Meanwhile, the therapeutic landscape has changed, more in the last 5 years than in the prior 3 decades. We now have immune checkpoint inhibitors like pembrolizumab and sasanlimab, IL-15 superagonists such as nogapentin alpha imbacacept, gene-based, can they get better names for these drugs? Gene-based therapy like nadofaragene and firadnovec, and innovative delivery systems like the gemcitabine intravesical system, formerly known as TAR-200, and reverse thermal hydrogels that deliver mitomycin more effectively. Most of these new agents were tested in patients with prior BCG exposure, but few have shown clear superiority when BCG is available and properly administered. You hear that? Few have shown superiority to BCG, but a lot of times you don't have the option. And that brings us to the big question. Are these therapies gaining popularity because BCG failed us, or because industry saw opportunity once the cracks in the supply chain became too big to ignore? Is this truly innovation or substitution? It's tempting to give credit to innovation. After all, immuno-oncology is everywhere, and bladder cancer is an attractive proving ground. But the reality may be more transactional. A fragile BCG supply chain created a vacuum, and the industry rushed in to fill it, with drugs that cost tens or hundreds of times more than BCG. Urologists desperate for treatment options, regulators eager to address an unmet need, and companies with deep R&D pipelines all converged to create a market where BCG unresponsive became not just a clinical category, but a commercial one. The paradox is striking. For the first time, we have real therapeutic choice in non-muscle invasive bladder cancer. And yet, the gold standard still remains rationed, locked behind supply limitations, rather than clinical evidence. Gold standard. Guidelines still say use BCG, but many clinics can't. So we pivot to newer, costlier, and sometimes less proven therapies. Patients who once received 6 installations of a trusted biologic are now given novel, expensive drugs, not because they failed BCG, but because BCG failed them. And that should make us all uneasy. We need rigorous head-to-head clinical trials of these new agents in the frontline setting, not just in BCG unresponsive disease. And we need policy solutions that stabilize the supply of BCG. Because really, why should a live attenuated vaccine developed decades ago be harder to obtain than a PD-1 inhibitor? If innovation is truly going to move the field forward, it should replace BCG on merit, not because supply chain failure. So, which came first, the BCG shortage or the innovation? Perhaps they evolved together, but unless we fix the supply problem, we may never know whether these replacement therapies rose by design or simply by default. And I'm coming to you and saying you need to fix that supply chain because patients benefited from BCG. Tomorrow on UroNurse, we're diving into one of the most exciting advances in men's health, aquablation therapy for BPH. I'll be joined by Alex Hughes, lead nurse practitioner at Austin Urology Institute, to unpack how robotically guided water jet technology is transforming the way we treat enlarged prostates. Aquablation precisely removes excess prostate tissue using high-speed, computer-controlled water, offering patients faster recovery, fewer complications, and less risk of sexual side effects compared to traditional surgical approaches. If you or someone you know is exploring treatment options for BPH, you won't want to miss the discussion on this next generation therapy that's changing the standards of care. So, tune in tomorrow on uronurse.com to find out more. I'm Vic Senese. Thanks for watching UroNurse, and don't forget to like and subscribe. And of course, for more stories, see you all next week.
UroNurse News, we've got the scoop, helping you stay in a healthcare loop. From Monday to Friday, we bring the view. UroNurse News, straight to